Thank you so much for inviting me. Actually, I met Willem last night for the first time, although he's been to my university many times. And actually, it's my first trip to Costa Rica, and I'm originally from Sri Lanka. It reminds so much like Sri Lanka, tropical environment. So thank you, and I'm going to actually build up on my colleague Koon's basic introduction. And it's going to be a little different. I'm going to give you some aspects of regenerative medicine that's more practical, what's being done in the world right now, especially in the United States and in Europe. And some of the couple of first slides are just the introduction of stem cells, actually beyond the blood stem cells. And then I'll talk about the FDA. Many of you may not be aware. So the regulatory body in the United States that regulate all clinical medicine is Federal Food and Drug Administration, FDA. So any clinical trial to actual approving standard of therapy has to go through the FDA. So I'm going to give a separate talk on the regulation, but I'll show you some of the therapies that involve stem cells that's been already under clinical trials, or very few that's been approved in the United States. And then also I'll talk about the two types of stem cells that are being now coming into treating patients. One's based on iPS and also embryonic stem cells. And the type of stem cells that actually is really taken off in the last 5 years is based on mesenchymal stem cells. Actually, this seems to alleviate many of the problems that the blood stem cells have, and it's just beginning to take off. So I'll talk about some of the introduction. So I'm showing this slide because we all think regenerative medicine is new. If you go to Greek mythology, they talk about regeneration of liver. So essentially, many things we think that are really new that we are discovering, it's already there. It's just we have to discover them. Same thing with regeneration. Many of you are aware salamanders can regenerate their limbs. So there are possibilities. Human species are one of the few that cannot regenerate. Why is it? So those are some of the secrets that we still need to uncover. So essentially, if Greek mythology talked about this regeneration, we should probably be able to discover ways to come up with methods to regenerate our cells that have been damaged. So in terms of stem cells itself, so this is very, very more fundamental than what even Koon had mentioned. So of course we have embryonic stem cell, which is the most primitive stem cell that's in an embryo. And again, like my colleague mentioned, characterized by these transcription factors that define it to be a stem cell. Actually, this is the part that's taken a lot of interest in the last 5-7 years. I'm doing the same problem. I'm going to use this. There's a lot of interest in the fetal stem cells, and the fetal stem cells can come from, not from the embryo itself, actually, from amniotic fluid, water and jelly stem cells, which I'll talk quite a bit about. So the water and jelly stem cells are from the cord itself, isolated from the cord itself. Also placenta and amniotic membrane itself. So these cells have become a good source of starting material for regenerative medicine, and one of the key reasons is because of a lack of an immunogenicity, so cannot be rejected. And then less potential is this adult stem cell, and of course the progenitor cells do not have the regenerative capacity. It's already decided to go into a particular lineage, like Koon had mentioned, to a red blood cells or a myeloid cell. So most of the focus is on these types of cells and also the stem cells themselves. And so how do we find out whether we have stem cells. So I'm just showing you one slide. This is actually was done. It's a very old slide from my lab itself. So this is a blood stem cell. So how we recognize that there is a stem cell, if you take a bone marrow aspirate or a blood, is there a stem cell? How many stem cells are there? So we figured out a way to do in vitro assays to recognize stem cells. So typically what we look for this type of an assay, it's called cobblestone area forming cells. If you put in a dish with a stromal cells, if you do have stem cells, what happens is they form a really tight refractile group of cells. Those are extremely primitive stem cells. For example, these two both have stem cells. These are all stem cells. But this is no stem cells, just regular blood cells. You do not have those refractile tight cells. So this is a way you could actually begin to understand whether your bone marrow, for example, has stem cells that can be used to treat a patient. So here, this is non-blood stem cells. Again, like Kuhn had mentioned, this is an undifferentiated embryonic stem cell, but then they form these embryonic bodies. So what's happening in terms of clinical applications is people retrieve these, isolate these cells in vitro in the lab, culture them, and manipulate them and prepare a cell dose to give it to patients. So these are some of the clinical trials that are being tested. And then for example, so the part that Kuhn alluded to actually has become the #1 upcoming treatment. The first type of treatment is for macular regeneration. And this is the cells that's been used after manipulating in the cells to be clinically transplanted into patients. So these are some of the basic morphologies of these stem cells that are being used. And of course, you can also get them to become neuronal cells in vitro. So this, I got it from the website from the US Regulatory Authority. Every treatment that's been approved for standard of therapy, not clinical trial, it's gone through clinical trials, and now it's become standard of therapy, is published. So you can see only these, there are actually two others that I didn't put in here, only a handful in terms of cell therapy or regenerative medicine that's approved right now in the United States. So of course the cord blood cells for transplantation is approved. When I say approved, it goes through a step called licensing. After phase 1, phase 2, phase 3 clinical trial, if you want to commercialize it, in other words, you want to charge a patient money and do the treatment, you have to get a license. So cord blood is licensed now. The other common thing of these approved is all autologous. The other one that's just been approved is autologous fibroblasts, and this is for treatment of improved appearance of wrinkles. And this is from this company called FibroCell Technology. Also, this therapy is now approved for repairing cartilage. So these are all different types of progenitors or stem cell tissues that's been in vitro expanded and has been shown to have some improvement or some efficacy. That's why they've been approved. And Provenge, many of you might be aware of Provenge. It's for prostate cancer. It was one of the first cell therapies that were approved now about 7, 8 years ago. And the latest one was last week, actually. This is one of the biggest breakthroughs in cell therapy. This is for cancers. So the first indication for standard of therapy that was approved last week by the FDA is for pediatric ALL. So you take your patient's own T cells and then modify the T cells to recognize the tumors, essentially targeting an antigen called CD19. And then the cells are sent back to the clinic and we infuse. So this went on what's called accelerated phase. 63 patients were treated. 82% showed remission. That was such a good result. This is now approved. Actually, my institution is the first place in Chicago now that's offering this therapy. On a clinical trial, we treated 4 or 5 patients, and beginning last week, now we offer a standard of therapy. So this is only a handful of patients that's been already a handful of studies that's been approved by the FDA. So I'm going to go through a couple of list of trials that's been undergoing clinical trials for regenerative medicine purposes. So this is, again, I got it from the FDA website. So whenever any treatment needs to go to clinical trials, you have to apply for an application. So this number that I list here, so that FDA has provided this number. Look at how many, this is just the last few years, it's exploded all around the world for macular degeneration. So these are clinical trials that are either completed or now recruiting. They all originate the cells that are embryonic stem cells or iPS-derived stem cells that's been expanded and manipulated by companies or entities and going through testing for macular degeneration. So if you were to look at several of them are from Japan. Actually, this is from United States, University of California. And then there's a whole host of others right here. Actually, there is one from Brazil that's recruiting for the same thing, but all the sources are embryonic stem cells, but with different flavors. And then also a hospital in China. But these are all US FDA regulated trials that are going through. So I expect this to become a standard of therapy in the next 2 or 3 years, licensed product. And they're all coming from ESCs or iPS cells. The next few slides, actually, I'm going to concentrate on MSCs. They're called mesenchymal stem cells. The reason this type of stem cells have taken on its own kind of life is because MSCs, you can take it off the shelf. It doesn't have to be autologous. They lack immunogenicity. So many MSC trials have shown you can just, like giving a pill, you can take a drug from any cells and give it to somebody else and there won't be any rejection. So where do the MSCs come from? Many sources. So this really shows you can isolate MSCs from endometrium, placenta, amniotic fluid. These are the two tissues that has really people have been using quite a bit. Umbilical cord itself, derived MSCs, and also bone marrow. I'll show you now people are realizing there's quite a few drawbacks of using MSCs from bone marrow because many of the trials, I would say in our last 10 years, have used bone marrow as the source, but the results have not been as promising as expected, but more promising results are coming from umbilical cord. And then you can differentiate it into all these types of cells. And so this actually shows the work that's been done from MSCs from all these different tissues. As you can see, this index really shows both research, development, and clinical use. Umbilical cord-derived MSCs have really taken off, and of course the bone marrow is there. The other one that's really take a prominent role is adipose tissue. Not because it's good, because it's easy to use. And that is what Kuhn had shown, that the patient that went blind was used from adipose derived, especially in a lot of Asian countries. They charge you money, they take your own fat cells, they then inject it somewhere else. So there is a term for this by the FDA. It's called non-homologous use of tissue. Non-homologous use means you take your own cells and put it into somewhere else for another use. In other words, taking bone marrow and put it in the heart is a non-homologous use. Taking bone marrow and put it in the bone marrow is homologous use. So the problems becomes, even using non-homologous use becomes a problem. So this is the issue with using fat, adipose, for regenerative medicine, people have realized. When you take somebody's fat cells, this is what you get. It has a fatty portion, liquid portion, and a cell pellet. So it's defined as stromal vascular fraction, SVF, which contains native fat cells and also liposuction. But if you take this and inject, what are you injecting into these patients? These are all the types of things that you're injecting. So you have adipose, fibroblasts, smooth muscle, endothelium, and blood cells. Also all these progenitors. But the active part, if it works, that truly will make a difference is this compartment right here. This is where the stem cells are. But the problem is when you take this liposuction, only a very, very minor fraction of this is true stem cells. So all the other things can have bad effects. And so using SVF without purifying is a big issue. And that's what's being done in many, many clinics, including trying to treat for wrinkles, to blindness, to other things, and it does not work properly. So a few years ago, this is a position paper that was published by ISCT, really defined what, because people were doing this, a lot of physicians were doing this around the world. So SVF really was defined what they came to an agreement, and then characterization of the population of adipose-derived stromal cells, ASCs, which has the greatest therapeutic potential, still remains unclear. So many of the things that's been done is to try to characterize this a little better. But I think the biggest use for mesenchymal stem cells will come not from the adipose, other types of tissues. So that's what I want to show you the next few slides. So the part that has really taken a lot of attention is MSCs from umbilical cord. And this is also not controversial. When a baby is born, you throw out the placenta, you throw out the umbilical cord. If you were to get the umbilical cord, the inner lining of the umbilical cord is a jelly kind of cells. It's named after its discoverer, Wharton. So it's called Wharton jelly MSCs, which has stem cells. And these are all the clinical trials. This is again in blue. So these are legitimate clinical trials that the FDA has looked at the applications and assigned a name. So these are all the clinical trial numbers. And these are preclinical and clinical trials that's been conducted in the US and around the world, and all for many, many diseases right now. But again, this is not a standard of therapy right now. It looks promising, has a long way to go, but looks like it may work. So many of us are familiar with doing clinical trials using MSCs from bone marrow. This goes back to about 15 years right now. And including my lab actually has a bank of MSCs from bone marrow from a company, whole bank. The purpose is if a nuclear attack comes along, they claim that these MSCs can prevent from bone marrow failure for nuclear radiation. So there are, and graft versus host disease is another indication that the bone marrow MSCs has been used. But it hasn't been as efficacy as we expected. The reasons are these. So if you were to get a very young donor, you have these very, very nice MSCs. These are really nice fibroblast cells. But if you get an older donor, no spindle-shaped morphology, few mitotic cells. So these types of cells are not very good for regenerative medicine. So that's where many of these original bone marrow stem cells were coming from adults. So, and also donor variability can be an issue. And also they have very differentiation potential. Also there are lots of subset of stem cells and many different issues. But the other thing is it's also low in numbers, so you have to really grow in vitro and expand them and create a bank and characterize them. So, and also, of course, it's painful to harvest and risk of infection. So people are trying to move away from bone marrow-derived MSCs and more concentrate on umbilical cord MSCs. And the other reason being, like I mentioned, there is no problem with rejection, immunogenicity. So if we were to get a brand new baby's umbilical cord and create a really well-characterized bank, it's not controversial, non-immunogenic, and it's very, very naive in terms of recognizing self from non-self. And so just to give you a quick anatomy lesson here, where these stem cells are coming from. So the umbilical cord itself can be isolated from them. So many of the cell therapy facilities in the United States are accredited by Foundation for Accreditation of Cell Therapy. In fact, actually now it's become a worldwide organization, and I am an inspector. I inspect banks around the world, and lately I have inspected several in Asia. Many of the cord blood banks that collect cord blood to save it for your baby to be used in the future now also give the families an option to save the piece of the cord. So some banks don't have the technology, they will save the cord. Others actually digest the cord, isolate the MSCs, and in couple of vials cryopreserve. In the future, they can create a bank out of it. So, and that area is just becoming more standard of therapy, not therapy, but collecting, and just like the cord blood banks, collecting cord blood cells. And then also has both the yolk sac and also placenta also has cord blood, also has stem cells that you can save. So human water and jelly stem cells seems to be the one that's taking off in terms of doing many, many more clinical trials. So I'm going to go through a couple of major characteristics of these cells. Why it's good? Again, it do not express HLA-DR. Also, some of these markers, but also do not secrete, also secrete prostaglandin E2. In other words, it suppresses the immune system. So these are good characteristics to have, and also inhibit differentiation and maturation of dendritic cells, thus no inflammatory reaction. So this is how these cells look like. And then it can easily given to a recipient without any immune rejection. So I just, in one slide, wanted to show you all the diseases currently they are trying clinical trials using this Wharton jelly stem cells. It ranges from blood disease to infectious disease to cancer, heart disease, connective orthopedic surgeries to injuries, and all the way to all these different diseases. These are all very early, but it seems to be promising, and hopefully in the next couple of years, at least some of these diseases, you may be able to see some promise and efficacy. And I'm going to finish up with this last one clinical trial that has used Wharton jelly stem cells. Seems to make a difference. So, both Kuhn and Willem are transplanters, bone marrow transplant physicians. So we use cord blood as a source for transplanting their patients, our patients. But one of the drawbacks of using cord blood for stem cell reconstitution is the engraftment of the stem cells takes a long time. Typically, we use G-mobilized peripheral blood stem cells or bone marrow. Within 11 to 14 days, it's completely engrafted, and a patient has a new immune system. But in terms of if you use cord blood, it takes 21, 22, sometimes 28 days. So this is a big issue without an immune system for that long. So this trial actually, used 20 patients. This is again preliminary, but it really shows that mixing Wharton jelly stem cells can really solve this problem of a bridge, creating a bridge for engraftment, and essentially treated these patients, and here is the results. Typically, like I mentioned, this is standard of therapy, 21 days for engraftment. The cells that were mixed with the Wharton jelly MSC, within 12 days, you could see the engraftment. And the cell dose that was used for mixing is not a lot of mesenchymal stem cells, a few million. Even with that, you could see an effect. So conclusion here, based on at least on this trial, which was actually published in 2013, is umbilical cord mesenchymal stem cells can enhance the engraftment of the CD34 cells along with after a cord blood transplant for further, although further studies need to be done. This really opens up a lot of other possibilities using cord blood as a source. One of its drawbacks can be addressed by using this method. And the last couple of slides is actually, like Kuhn mentioned, we were thinking of using bone marrow derived MSCs about now 15 years ago for myocardial infarction. And people had done many trials around the US, but with very little long-lasting results. But right now, using MSCs derived from umbilical cord, the water and jelly, it seems to actually taken another second life again, trying these new types of stem cells. And the initial results are already in. It shows intracranial delivery was safe, so directly injecting into the myocardium also significantly improved the viability of heart function, and also no immune-related issues were observed. But large-scale studies needs to be done. Many of these studies, you really need to do large-scale studies to really see the whole spectrum of adverse effect and efficacy. So in the next few years, we may see more of these types of stem cells being applied to other indications, including orthopedic surgeries and other types of injury-prone conditions. But what I really want to emphasize in the way things are done right now, the low-hanging fruit is not the best, which is using adipose tissue. Because also what's not been considered using adipose-derived MSCs is many of these patients whose adipose is removed, they already have medical conditions. Either they are diabetic, overweight, other issues. So these MSCs from these patients are not the most healthy. So using them may really kill the field, that even for the other good MSCs may not get a good fair shake if people keep using adipose because it's easy to access and get it. So, but water and jelly MSC seems to be one of the sources that may make a difference. And then my last slide is cancer, diabetic, autoimmune, cardiac, neural, and genetic. Many more studies can be done using these MSCs and new stem cells. And I'm going to stop right there. Thank you.